Please listen carefully.
Hello and welcome to GasGasGas. This is the best podcast for the FRCA primary exam. Our goal is to fill your brain with all this highly useful information. You might be in the gym right now, commuting, or ironing your scrubs. Regardless, the revision is eventually going to end, but for now, expect facts, concepts, model answers, and the odd tangent. Make sure to check out gasgasgas.uk. The show notes there's loads more detail. Make sure to like and subscribe. Anyway, buckle up, get ready for your mind to be bent into a new shape, and let's get on with the show. Hello everyone, this is James at GasGasGas, and as promised, I sit here thinking about how opiates potter through the epidural and intrathecal spaces on this joyful Saturday morning. I've had my nap, I've done my gardening, and I'm ready for action. So let's get on with the show. So why do we actually bother putting opioids intrathecally or epidurally? Well, it all actually kicked off in the 1970s when Yaksh and Rudy realised that sneaking opiates in and around the spinal cord achieved heavily saturated cord opiate receptors. This was an ambitious hope because they desired opiates to not squirrel off into other areas of the human, leading to all the side effects of opiates, which we all know and we could all recite. But we're going to talk about constipation, respiratory depression, feeling sick. However, whilst lots of people started putting intrathecal or epidural opiates into people, the impression I might have got from some of my reading suggests that people were hoping beyond hope that they didn't get the sequelae of systemic opiates. Unfortunately, a bunch of patients stopped breathing, a number of them with terrible consequences, and ultimately it transpired that concentrated doses of opiates were creeping their way northwards, pickling respiratory centres and leading to respiratory depression. Remembering, guys, that the respiratory centres are in the ventral respiratory group in the medulla oblongata, the VRG. So this probably harks back to the needs of doctors to be inherently suspicious when confronted with something that sounds too good to be true. We should assume that it is hecking sus, and that perhaps when someone comes out saying this drug cures 95% of all ailments, a la paracetamol-oxyfruzy-bendroniumycin, go on YouTube for that cracking song, we should think twice about whether or not we should believe said claim. So, why do we still do it? Well, whereas IV administration of opiates achieves a plasma concentration, and this plasma concentration is subsequently passed very close to nerves, because nerves require a blood supply, and that blood supply is in the shape of capillaries, or the vaso nervorum, and therefore it's quite close by to its effect site. So why don't we just give everyone systemic opiates? Well, it is true to say that giving someone intrathecal opiates does achieve a high concentration of opiate in the cord with lower potential side effects, and also alterations in how long that dose lasts for, which we're going to get into more detail a bit later in the show. So we probably need to start thinking about the epidural space before we get into all the minutiae, and the intrathecal space before we go even deeper. The epidural space from an anatomical perspective. In an exam they might ask you, what are the borders of the epidural space? And if you've not thought about it, you'll be wasting valuable time trying to think it through and remember your anatomy. So you've got to imagine it like a cylinder with capped ends. The top is limited by the foramen magnum, i.e. the hole in the base of the skull that the cord passes through, as the dura fuses with the skull base, therefore creating a barrier. Inferiorly, or caudally, the epidural space finishes at the sacral hiatus, where it's covered by the sacrococcygeal ligament, the place where you can stick a needle and do a caudal epidural. And then the front, back, and sides of the epidural space as it goes from top to bottom. So the front is bounded by vertebral bodies, discs, and the posterior longitudinal ligament of the vertebral bodies. The posterior aspect is bordered by the ligamentum flavum. That's the one we go through when we're doing a epidural. And the vertebral lamina, i.e. bone. And the lateral aspects are bordered by the pedicles and the intervertebral foramina, because the spinal nerves have to get out somehow. So that's your anatomical borders of the epidural space. Now, if you're being smart, you could also say that the meninges are also the internal border of this, because actually it's a tube in a tube, which most of the human body does seem to be once you take them apart embryologically. So we've talked about what borders the epidural space, but what do we find in the epidural space? Well, it's full of fat, but also a dural venous plexus. This is called Batson's plexus, and this is actually a venous network that plumbs from your sacrum all the way up your epidural space. There are no valves, so that means that infection down low can journey up high, and that tumour cells can traverse this space also. Where you find veins, you find arteries, and there are these so-called segmental spinal arteries that ultimately traverse the meninges, delivering blood flow to the anterior spinal artery and the two posterior spinal arteries. If you were to be tottering around in this space and having a look about, you would also stumble across spinal nerves. Remember, we've got intervertebral foramen, we've got a spinal cord. Those nerves have to get out somehow, and they journey through this space. So just imagining ourselves, we're a morphine molecule. We've been rudely injected down an epidural catheter into a fat space, and we're thinking, oh, we've got our work cut out here, we've got to go on a journey. And that journey is, they've got to totter through epidural fat. They've got to negotiate around the epidural venous plexi and avoid getting soaked up and squirreled off into the plasma. They've then got to eke their way across the dura mater and then the arachnoid mater. And then, as if they're crossing the river Styx, they've got to percolate across the CSF before finding themselves scratching their head, thinking about going through the pia mater, and ultimately percolating through that spinal cord. Where is the chief site of effect? Well, I'm sure you know, I'm going to tell you anyway. The chief effect site in the spinal cord for opiates is in the dorsal horn grey matter, which is where the cell bodies are, guys. Remember, the white matter is myelin sheaths of nerves, and it's in the substantia gelatinosa, which is located in rexed lamina 2. Rexed lamina are a histological way of splitting apart the spinal cord. So that morphine molecule that you've been imagining yourself as has to go on quite an adventure. The ability of that morphine molecule to make that journey successfully. What barriers are in its way from a physico-chemical manner? And certainly those things are important too. And that's why we love anaesthesia. So how lipid soluble the agent is an important factor. Its protein binding, its molecular weight, and its pKa. So lipid solubility, what does that really mean? I'm going to tell you a few times throughout this podcast. If you're very, very lipid soluble, this is actually a detractor because it means you're more likely to either get bamboozled, if you're a fentanyl molecule, for example, into soaking yourself into epidural fat and being quite happy, sat there, not doing very much and just minding your own business, or getting pulled up from the epidural fat space by blood flow through those veins and then off you totter to other parts of the body, which is less than handy. It's molecular weight, so we can all remember Fick's law, but the crux of that in this case is the bigger the molecule, the slower the rate of diffusion. Its pKa is also relevant from a unionized versus unionized perspective, remembering that ionized molecules aren't so great at traversing fatty spaces, and lipid membranes are quite a barrier to an ionized molecule. So it's the unionized component that we're interested in when we're thinking about how it's going to get where it needs to go. And protein binding comes about if it's heavily protein bound, you're going to have less available drug to make that journey. So now we are all capable of imagining the journey a molecule goes on, the anatomical environment it is percolating around, and some of its implications that govern movement through that space. So now we need to try and make some sort of best effort at comparing and contrasting opiates when we put them in the epidural space versus opiates when we put them in the intrathecal space. Now, some robust rules of thumb is that you need to put a larger dose in the epidural space than the intrathecal space. That bears out purely logically, doesn't it? And that if you are citing drugs in the epidural space, their propensity to cause side effects like nausea, vomiting, etc. are higher because you've simply given a bigger dose and it's a nice vascular area, so it's going to escape off and tickle other receptors in other parts of the body. This does mean, from a safety perspective, that you need to be really keeping your head on your shoulders when you're thinking about where you're injecting the opiates that you picked, so you don't accidentally give an epidural dose intrathecally. Another thing to keep an eye on is if you're using morphine, morphine comes in 1 milligram preservative free, and that is for intrathecal use, but also 10 milligrams non-preservative free. Both are in a mill, and it has certainly happened whereby people actually give a massive overdose by inadvertently picking the wrong concentration of morphine, and then some patients will be fine and they'll just keep breathing, and other patients will certainly stop breathing later, and it will be very terribly embarrassing. So you've got to really keep your head on your shoulders and make sure you've definitely got the right drug and the right concentration. So we're going to compare the two extremes first. So morphine versus fentanyl. We all know that fentanyl is incredibly lipophilic, whereas morphine is not so lipophilic. Therefore, you can imagine that morphine takes longer to work because it takes longer to get where it needs to go, whereas fentanyl will work quite quickly because it can simply get there faster. However, we know that something that's more fat soluble is more prone to being sequestered elsewhere, and when we want to compare their duration of action, morphine will last much longer, whereas fentanyl will not. However, interestingly, morphine prefers water than fat in some ways compared to these other drugs, will have a greater propensity to cause respiratory depression because it will float around in the CSF space when it gets there, or if you've introduced it there, for much longer before it soaks into the spinal cord. That means it can go up and down more readily. And it's that cephalad spread, i.e., up to the brain, that has been associated with respiratory depression in neuraxially administered opiates. So just to quickly compare potential dosing options, and we're going to think about the intrathecal doses here, we know that fentanyl is 100 times more potent than morphine, don't we? It's like, we give micrograms of it, not milligrams of it. So you would make the argument that you would potentially need to give 100 times less, wouldn't you, of fentanyl than morphine for the same analgesic effect. Now, this doesn't actually bear out in reality, and that's because an IV dose is different to a neuraxial dose, because we're putting it into a different environment, aren't we? And therefore, they behave differently. So you might give someone 100, 200 mics of intrathecal morphine, where you may in fact give them 25 to 50 mics of intrathecal fentanyl. So actually only perhaps a quarter of the dose as opposed to a tenth. And the reason this bears out from a kinetics perspective is we're rocking back to fentanyl's lipid solubility and the space in which we're putting it, where there is buckets of lipid. Now, I can tell you that myelin sheath is not a place where opiates are going to have a significantly large effect. But myelin sheath is delightfully fatty, isn't it? And therefore fentanyl likes to float off towards the myelin, whereas the effect site is going to be on those cell bodies. Now, this is all spectacularly fascinating, but we don't want to get too buried off in the long grass of thinking in too much of an excess of detail, although it is a delight, about how these things work. But for anyone who is further curious, there's a really interesting paper by Hallworth and Fernando that explores fat solubilities in greater detail, and they use the octanol water buffering coefficient as a way to think about how these agents partition into fatty spaces versus non-fatty spaces. Now, an octanol water buffering coefficient, or OWBC, of between 100 and 500 yields a good capacity of an agent to tottle across the dura and get where it needs to go. Fentanyl has an OWBC of 813, and on the other end of the spectrum, morphine has an OWBC of 1.4. So you can see there's quite a stark difference there. Whereas diamorphine, which we're going to come on to next, actually sits very neatly between that 100 to 500 range at 280. So we can certainly imagine that that's going to be a nice tidy drug to pick. So thinking about the behaviour of diamorphine now in this situation, we could just simply imagine that it is middling. It is middle of the road, average. It's getting C's in its GCSEs. Its lipid solubility is middling. Its onset time is 10 to 20 minutes. Morphine, 15 to 30. fentanyl 5 to 10, nice and fast. How long does diamorphine last? About 8 to 12 hours. And does it escape into the CSF and soak off up into the brainstem in our ventral respiratory group, causing depression? Well, it causes less of that. It's in between morphine, which certainly likes to go there, and fentanyl, which can't be asked to go that far. It's quite happy soaking up the fat, living in the butter. And this is why diamorphine is probably quite a nice choice in anaesthesia for caesarean sections where you need pretty robust pain relief, pretty quick, but actually it doesn't need to last forever because maybe we patriarchally think that it's not that painful having a caesarean. Now, it probably is. And actually, if anyone knows about any research that compares epidural versus intrathecal diamorph following caesarean section and opiate requirements, that would be cool. I think I came across something, but I don't want to imagine that I know what I'm on about on that front. When there was a diamorphine shortage in the United Kingdom, there was a fudge whereby, for elective sections where there wasn't a time pressure, we were carefully drawing up a dose of intrathecal morphine and adding 20 mics of fentanyl to it so that we got some quick pain relief and then some prolonged pain relief for the elective section patients. We are fortunate enough to have pre-made 300 mic doses of diamorphine that are mixed up in a sterile manner that we can aspirate into our spinal anaesthetic mix, and therefore it's nice and quick instead of having to rock your internal potions master drawing up, diluting, measuring a dose of diamorphine into your local anaesthetic. So just to summarise there from a clinical implications for you guys perspective, fentanyl, quick to work, quick to wear off, doesn't really escape anywhere, good for short procedures. Morphine, slow to work, that has a prolonged effect, carries a risk of respiratory depression. However, in the doses used, like 200 mics as opposed to the 500s, etc., that were perhaps slightly more old hat, the incidence of respiratory depression is less. It is proportional to the dose. And diamorphine, middle ground. So you can imagine that a patient who's having a laparotomy, where you don't want an epidural, or maybe a big laparoscopic procedure like an anterior resection, clearly would benefit from intrathecal morphine because they're still going to need a general anaesthetic, and really you're using that intrathecal morphine to cover their pain when they wake up. You're not really putting it in there to cover your anaesthetic. Now, when you administer neuraxial opiates, the chief clinical effect is obviously analgesia, and it works really well, doesn't it? But patients still get nausea and vomiting, and they're going to get it more with epidural agents versus intrathecal agents. I'm actually tempted to slightly alter my practice. I've been putting 5 milligrams of diamorphine down epidurals at the end of epidural top-up caesarean sections. I think I'm actually going to back off to 3 because there's some evidence that suggests that's less. But do whatever happens in your shop. Maybe I've just been overdosing people. And then I'm sure we've all seen it. People get itchy, and you can definitely spot it towards the end of a caesarean section. They're sewing them up, and then this poor lady who's been through quite a whirlwind of emotions starts just, a little bit of a scratch here, a bit of an itch there. You can spot it, and you can look very sage if you go, oh, you're feeling a bit itchy, are you? It makes it look like you're paying loads of attention, which obviously you should be. But often what happens in recovery or on the wards is when patients are itchy, the nursing team think they need antihistamines. Now, unfortunately, this isn't really a histamine-mediated mechanism for itchiness. And I try and explain to patients that really they've got an itchy spinal cord, and the only real way to stop the itching is to give them naloxone, and that generally doesn't help.
As naloxone would obviously impair the analgesia. Now, if the itching is absolutely intolerable, then counsel the patient and give very small doses of naloxone until the itching is resolved, like maybe 25 mics or 50 mics, just the teeniest amount, until their itching is manageable. You might need to go back and give this again, because we know that the half-life of naloxone is quite short compared to these opiates.
But if you just rock up to someone and say, well, you're itching and we can do something about it, but you're going to be in loads of pain, so just buckle up in here, bite on this leather, and put some socks on your hands so you don't scratch yourself to smithereens, you're probably not managing that communication scenario very well. But really, I think the most important thing is to explain why. And I don't think that mechanism is truly fully elicited, and I just say, I'm really sorry, that's my fault. The pain relief I've given you has made your spinal cord really itchy, and that's why your skin feels really itchy. But obviously, guys, make sure it's not a living reaction.
I hope you found it
useful.
useful.
If you found it awful, do let me know. Please like and subscribe, register with whichever podcast platform you find yourself using, and leave a comment.
We don't really have a clue.
I just want to make sure that you guys know that every day you are getting better at this. There is a bucket of content to try and consume, and it is like drinking from a fire hose. Take it day by day. Don't overcook yourself. Don't freak out. And keep studying.
Unlucky that new drugs come along, well, then we might feel like we have a reasonable idea of what we can and can't do. Right,